Thank you very much. Thank you very much, Debs, and thank you very much for the invite to come and speak. Yeah, I love all things that reduce harm and challenge stigma. You'll hear from Katy in a wee bit, but I'm going to speak to you mainly about peer naloxone supply in Scotland. So as was mentioned earlier, up in Scotland, unfortunately, we are in the grips of a public health emergency. We had 1,172 deaths in 2023. 80% of those opioids were directly implicated. This has been said earlier, was more than double from just 10 years ago. 2.7 times more likely to die in Scotland than you are the rest of the UK. Forward-facing staff are suggesting things are not improving, and I think as we've seen about the toxic drug supply, you know, we might have a bigger hill to climb coming forwards. So this is just a breakdown of the opioids that are implicated. Like I said, 80% or 937 people who died tragically in 2023 had opioids directly implicated in their death. Why a peer supply? So I would argue that peers have privileged access, increased reach and instant credibility within the communities of the people most at risk of drug-related harm and ultimately drug-related death. I would also suggest that we have the most skin in the game. I've been burying my mates for a couple of decades now. Some of the peers that have been involved in some of the projects, that's much, much longer. And tragically, you know, even more recently, it's their friends and their kind of family that are passing away. So that's why a peer supply. We've got 3 key objectives to the project, and that's to establish, embed and support a high-quality peer naloxone as a core service across Scotland. We want to ensure those involved in the projects have a direct voice into the running and implementation of those projects and wider harm reduction strategies locally. We also want to connect and offer support to any external unfunded projects as well. So we've created a couple of national networks that I'll mention in a wee bit. 5-year programme. Initially, we were funded by the Drug Death Task Force Innovation Fund, and we're now direct funded from Scottish Government with a strong emphasis on the prisons rollout, and I'll speak in a minute about some of the prisons work. So this is just a very high-level kind of overview of the projects. We delivered 8 community projects, 6 peers progressed onto full-time roles once they were kind of finished with the naloxone fixed-term projects that we were delivering. 1 joined the joined SDF in a national role, so he's actually my colleague now. He was one of the first sessional workers up in Dundee to do some of the sessional work. He now works with me on this kind of rollout, and we've had 2 peers enrolled into the SDF national traineeship. To date, we've set up 7 prison projects. For the last year that we've got data for, 47% of naloxone from prisons was made by peers. And probably at the time that data was captured, we were in way less than half of the prisons. So I imagine that figure's going to kind of raise up. The chap in the picture, he's actually on community placement, delivering training and supplying out in the community while he's a resident. So building a national network. We've got 40 peers across Scotland attending a national worker network forum. We have quarterly meetings. We've been meeting every quarter for the last 3 years. We have a standing agenda item from Public Health Scotland on emerging drug trends, and it's also a conduit for peers to feed into changes they're seeing in the drug market, kind of locally in the areas that they're working in. And it's a forum for sharing good practice and knowledge exchange. So a little note on the effectiveness. So to date, SDF-led projects have delivered 4,673 kits, of which over 70% were first-time ever people were supplied with kits. Peers have worked over 5,500 hours, with the vast majority of those being paid for their time and expertise. I would argue that the sky's the limit. I would love to see the peer role being expanded further into dry blood spot testing, IEP provision, wound identification, referrals, all this sort of thing. And I believe that embedding peers within existing staff teams really helps to increase that skill mix and kind of increase the diversity and responsiveness to the changing drug market. Some of the learning so far, there can unfortunately sometimes still be a reluctance to employ people still using or people even still prescribed OST. PVG benefits concerns, the timeline for recruitment can be a real issue. Staff capacity, especially in the kind of prison environments. Cultural change is needed often, to be honest, as well, from different kind of large partners that we're working alongside, such as the NHS and the Scottish Prison Service. Short-term funding, We have seen some successes with some of the community work with ADPs then funding a continuation, but that hasn't happened everywhere. And I would argue and suggest that then we're going to lose that learning, we're losing that reach, we're losing that credibility in those areas. Some of the facilitators, so having a progressive approach to recruiting people who are using drugs, who are on prescriptions, I would say is a must for this sort of work. Having a proactive coordinator locally that really knows the lay of the land, they know the people already, they would usually be able to kind of, offer the opportunity to people that would be ideally suited kind of straight off the bat. The creation of a national framework, so we work with the Scottish Health Network, and we've got now for the prison environment a nationally approved framework, so we would be able to implement in all of the prisons, fingers crossed, all being well. Widely advertising the peer role amongst, all external partners. So with the community work, we would usually partner with one third sector provider, but we want the role to be kind of provided right across the kind of board so that more and more people can apply for it. I think some of the pressures that we faced in the prisons as well recently, the overcrowding, people will probably be aware of the overcrowding kind of environment that we've got, and then the early release schemes. There's been a really high turnover of people kind of getting out and coming back in. But yeah, in a nutshell, that's the work to date where we're up to. We're funded to the end of the Parliament, so we're hoping to get into the rest of the prisons if we're kind of able to. And please do come and grab me at lunch if you want a bit more detail or to dig into some of the kind of more granular stuff. We are certainly on a mission, and I know the peers are so motivated. And, for me, the biggest thing is they're making that impact and the empowerment of them making a change in their own communities. And I think where we can get policies and procedures out of the way to facilitate that. So with that, I'm going to hand over to my esteemed colleague and friend, Katy.
Thanks very much. Always very hard to follow Wes, and that was a great overview. We wanted to talk a wee bit more globally about the work of the wider project. So Wes's team sits within our broader team, which includes peer research work. So we've done many different projects evaluating services, doing mystery shoppers and things like that. But the thing I'm going to talk about today is a Scottish Government funded programme over 5 years, which is around developing a national network of living experience. So I'm going to give you what we're talking about. So I've got a bit of a definition there. So we are talking about people that have direct experience of living with a drug problem. So people who are currently living it now really is what we're saying. So that might include people who are currently using drugs, but it could also include people who are accessing medication-assisted treatment or other forms of treatment and support. Why are we talking about this, and why are we making the distinction between lived and living? Really, it's because historically we're aware that the kind of lived experience voice, certainly within Scotland, has tended to be from people in really long-term abstinence-based recovery. So it's been like, people that have maybe, been using drugs maybe 20 years ago plus. And we recognise that it's really key that we do listen to those experiences. That's part of it as well. But also really important that we recognise the voices of people who are currently experiencing drug problems, because we know that those people are marginalised and disempowered. So in terms of people currently accessing treatment, why do we think that's important? So we know that current experience is different from historic experience sometimes. There's different trends. We've talked about nitazines and things like that. Harms and treatment needs also change, and then people's perspectives change, over sort of longer periods as well. All those things are important to bring together. So I guess the point of this project is to create different spaces for people and also spaces for everyone to come together. So looking at that wider lived experience umbrella, and that might include family experience as well. So a wee bit about the programme. 5-year funded, which is a total luxury in Scotland, let me tell you. There's very few projects I've ever seen have been funded for that long. So we're about 3 years in at the moment. And we have regional groups in different parts of Scotland. So we have, we're certainly going to expand to at least 14 areas, but they're in about 12 areas at the moment. And these are just safe spaces for people with living experience to come and bring what matters to them. They're their groups, they set the agendas. people can have literally used before coming into the group. There are no criteria to attend. People don't need to be stable or any of these other labels that we sort of demand from people. And it's really about what they want. So at the moment, we've got 12 groups meeting weekly, and that's got at least 120 people attending, and that can fluctuate. Harm reduction training happens there as well, so Wes often comes in and does inputs as well. We make sure everyone is supplied with naloxone. So obviously festive period is massive for us, so seeing that people all get training before that, and then also helping people to access drug checking. So things like there will be a pilot in Glasgow, hopefully a bit like the Thistle service, so the safer consumption facility that's a bit delayed, as is drug testing services, but these will be operational. But at the moment we're supporting people to use the Wedinos system, so handing out envelopes, paying for their postage to send samples away, and then also doing nitazene testing strips as well. There's a national network, so all the regional groups come together with reps and meet nationally, so they do that usually about 4 times a year. And we're just in the process of looking at sustainability and autonomy, so constituting the group. So the first thing we're going to do is constitute the national group, providing people with vocational qualifications. That could be health and social care, advocacy, community development, things like that. And the next part is a peer magazine that we've just been recruiting for. So this will be a peer-led publication, podcast and things like that as well, that will be for the community and by the community. So Amir and Stephen advertising the group there, but this is the flyer that we give out to people to engage people to come along. And as I say, they set the agenda. These are the themes that people bring. Medication-assisted treatment, so this is a very hot topic for us in Scotland at the moment because recently we introduced new treatment standards focusing on medication-assisted treatment. The biggest things that comes up is, so one of the standards was to provide people with same-day prescribing. On paper, that's said to happen. What we find when we do qualitative work is it doesn't happen in practice. So that's one of the key things that people raise as access and choice around treatment options. Mental health is a massive issue, people just struggling to get any form of assessment, never mind support. So access to statutory mental health, things like that. And then housing, that could be everything from homelessness, kind of being in temp accommodation, but also just housing repairs. So one member of our group, for example, was sitting in a flat with boarded up windows for 3 months, came to the group, that was raised and we were able to get their accommodation with suitable repairs and things like that. So there's quite granular changes that happen as well as the bigger sort of policy changes. And then just to sort of finish off with some of the challenges, if you do want to go on and do a sort of network yourself, Wes touched on capacity and resource. We just don't have enough staff to get out to all the areas we'd love to. So just looking at Scotland, obviously big geography, so I'm from very far up north. The rural sort of complications, we could have groups everywhere if we had the resource. So we've had to sort of pick the sort of busiest areas and then look at online hybrid meetings, things like that. What we're finding is there are no pathways for people often. They are there on paper, but we get lots of people coming along to the group because they just can't get support from regular services, so the system just not working for them. We find buy-in from the alcohol and drug partnerships pretty challenging. So we pay people to come, so we give people cash, so they get a PayPoint voucher which they exchange for cash. And we had lots of pushback about, but won't they just buy drugs with it? And we were like, well, if you're staff, we don't pay you in vouchers. You can get cash, you can be paid, so this is okay. So there's a bit of hearts and minds transformation there as well. And yeah, just meeting people where they're at, because we have no sort of restrictions on how people attend. That means that we're dealing sometimes with people in different levels of crisis, sometimes need to come in because they're quite at risk from the substance use that they've maybe just used before coming to the group, and often on the fringes of treatment as well. So to give you one example, we had 56 people rock up to a group in Ayrshire, 11 of those were in treatment, so quite a lot of people not engaged with treatment. And in terms of how we've responded to those challenges, it's really just honing that approach, So learning from the challenges that we've had so far and just using the evidence from the other areas about how to do this. The biggest thing we need to do is have a robust management group around it, and that's having all the different partners around the table, really. So housing reps, mental health reps, addiction services, things like that, all the different holistic services that people might need. And then also holding them to account, so having things like action trackers to make sure that they are making the changes to local policy and protocol. It's a big challenge as well, so all the staff that are involved in the programme have lived experience themselves, so anyone that co-facilitates in any areas also have to have lived experience, because that was one of the requests of the group members. That can be a challenge in some areas as well, so maybe just not having people that maybe have their own lived experience, and then just the buy-in again from partners about how important they see this work, because sometimes we're giving them a lot of feedback that they don't actually want, because it might mean that they have to transform their services as well. One of the challenges we had was around the mental health support, so we actually decided to get a psychology placement. So we've got a PhD student in their final year that does health psychology work with staff and group members to provide things like psychoeducation, and then also a counselling service in-house as well to help people where they aren't able to access those other services. And then also trainee placements, things like that as well. So that's a bit of a whistle-stop tour of our work. But my email is up there, and please, as I said, do come and grab us at the break. Be very, very happy to talk about any of the project work, and thanks so much for listening. Thank you.